Okay, everyone, we're going to get started today. Today we have Dr. Chang joining us. Thank you for joining us, Dr. Chang. Round of applause. Very nice. As always, no financial disclosures for either of us. We like to learn a little bit about our expert slash discussant before starting with the case itself. So Dr. Chang is a associate professor of medicine here at WashU in the Division of Hospital Medicine. Also very involved with the WashU Medical School and the medical students. He's the inpatient clinical immersion co-director and the interprofessional thread director as well. In terms of training, he got his undergraduate degree at Yale University before matriculating into medical school, the University of Chicago. Started his internal medicine residency at USC, but then moved to NYU. The client for this case is a 67-year-old female with a past medical history of amyloidosis, RLS, IBS, GERD, and she's presenting with altered mental status. And so, Dr. Chang, you provided or sent this schema. So do you mind kind of going over that with us
Sure.
and giving us any other thoughts you
So
have?
how many of you guys use clinical problem solvers? Anybody in the room? Okay, yeah. So they have some like kind of nice schematics. I don't think they're totally comprehensive, but I think it gives you a good sense, which I think is actually really important when you think about something like altered mental status, which is so broad and can mean so many things. I think that's the challenge is what does really altered mental status mean? Like it's so non-specific that it actually becomes very hard to really sort of narrow things down. So, they have this sort of schema, and I think what they really start with is like sort of what are the things that you can reverse right away, right? So glucose things, opioids, some sort of like respiratory issue that you need to intubate. So those are things that they sort of start out with, which I think is really important because for a lot of us, especially the interns overnight, like you get called for altered mental status. That's sort of the first things that should be coming to your mind is like, hey, I need to sort of handle this. And then you kind of get into these sort of more common things that we think about. So the things that I add that I didn't really love about their schema was just like, I think in the geriatrics patients, which we have a lot of, there can be really common things that are causing them to be altered that are not so like a diagnosis, right? Sometimes they're in pain, sometimes they're constipated, sometimes they have urinary retention. These are things that can cause, mental status changes and that you can actually reverse and doesn't have to be some big diagnosis. So I sort of added that. And then they had this whole other area, but I think the first thing you always think about is neuro. So that's why I always sort of have a different category for that. And then you can go down the metabolic, infection, toxins. Those are all the sort of common things we should think about. I think the one that I personally always forget about when I see altered mental status is the hypercarbia, right? I feel like sometimes it just doesn't occur to me in that moment. So that's always one that's why this schema kind of helps me always remember that part of it. So that's kind of my approach to it all. Any questions about this or any other approaches that people have? Because this is a common yet really frustrating one. I would say as a resident, this is my least favorite one. They're like, oh, someone's alternate. I'm like, oh my God, what does that mean? So any other thoughts on this one from the group?
No? Okay. All right. I think you summarized it well. I'm sorry for giving you your least favorite subject. Did not know that. I'm going to give you some more information about this patient, and I hope it helps rather than throwing you into a loop. So this patient, 2 years prior to presenting to the hospital, she started to develop some bilateral lower extremity pain and numbness. It was on right more than left. She got an EMG and a nerve conduction study, which I'll show in the next slide. And then 6 months prior, she started to develop some weight loss. It was about 20 to 30 pounds by the time she presented. And then 3 months prior, this information is all provided by her husband because she actually can't provide the information. So per the patient's husband's description, she developed a wide base gait. And then 2 months prior, she started to develop some worsening mental status. It started out with some short-term memory loss and some dysarthria, and then progressed to the point where she was oriented only to herself, and she wasn't able to complete any of her activities of daily living, really in like the week prior to admission. And then besides that, she or her husband denied any fevers, chills, B symptoms, skin symptoms, lightheadedness, dizziness. I wrote numbness there, but that's not correct. GI symptoms, cardiopulmonary symptoms, nothing else going on. So let me show you this EMG and nerve conduction study, and then we'll come back to this HPI. So this was done about a year and a half prior to presentation. It showed evidence of mixed sensory motor peripheral neuropathy with axonal loss affecting the bilateral lower extremities. Okay, so that's a lot of information.
Yeah.
What are your thoughts on this? And then also kind of the time course of the worsening mental status.
Yeah. So I think, that first slide we had about sort of altered mental status, that's a lot of like acute stuff, right? That's happening acutely. This seems much more chronic and sort of long-standing. So when you think about numbness and wide-based gait, what does that make you think of? What kind of abnormalities are we thinking about or causes? Any thoughts? What if I told you they had like a macrocytic anemia? What would you think of? B12 deficiency, right? So that could be possible. I mean, she had this irritable bowel syndrome. I don't know what that really means. I think a lot of the history is very vague, right? Restless leg syndrome, not sure what that really means. Amyloidosis, right? That's like a buzzword, right? We remember that from med school, but that can be so many different things, right? That could be AA, that could be AL, that could be transurethral, like there's all these sort of things. So it's unclear what all of that has to do with this, but this is certainly very chronic. And so it does make you think of, maybe it's like a B12 deficiency, maybe it's some sort of chronic inflammation. And then the worsening mental status over 2 months, right? So that is sort of interesting when you think about like what could cause sort of chronic mental status changes over time, right? So any thoughts from the group? How would you organize this? How do you organize this? Chronic worsening mental status changes. It's a little different than the one schema I just showed you. What are some things, big categories? Okay, dementia, right? So it could be a dementia 67, right? Although it seems a little rapid, right? So what could be rapid things that cause dementia? Yaakov, right? What else? Was that again? Structural, right? So what are you thinking about? Like strokes, tumor, stroke, bleeding, strokes, right? What else? So strokes, I think, kind of vascular, big categories like vascular types of things. We're thinking about like, prion, stuff like Yaakov disease, right? There's different kinds of dementias, frontal temporal dementias, all those kind of dementias can happen a little bit more quickly, right? What else? What other big categories? Talked about sort of vitamin deficiencies, right? That can sort of happen over time. What else? Say again, toxic exposures. Okay. Polypharmacy, ooh, that's a good one, right? Common things being common, right? Polypharmacy. Certain infections, like what kinds of infections? Syphilis, yes. Very common. Yeah. Yeah. HIV, yeah. Good. So chronic things like HIV, syphilis, those are kinds of things that we see actually, we see a lot of neurosyphilis here, very chronic stuff we see all the time. Okay, so that's mental status, right? So then I'm sure the CPCs will always do this. So what about the numbness over 2 years? What could that be, right? Taking problem by problem, doing differentials, and then seeing what sort of mixes together. What causes numbness, right? Greater than left, although the EMG seems like it was pretty bilateral similar, right? So she might feel that, but so what things could that be? Yeah, yeah, right. That's what I thought at first. I was like amyloid neuropathy, right? It's like CPC, so you're thinking about all these things, right? What else? I mean, I don't personally know a lot about EMG, so I'm not sure what sensory motor, if there's a different one for that kind of differential versus something else. But yeah, I just start thinking about anything that causes sort of numbness, right? So diabetes, right? That's the most common thing we see. It could still be B12 deficiency, right? They get paresthesia, stuff like that. So that could be possible. She has this wide-based gait. What about the wide-based gait? That's interesting, right? What does that make you think about? Say again? What, waxy wobbly? Okay. Talk to me more about that. Uh-huh. Yeah, 3, yeah. Yeah. And that can also, you can also see that with B12 deficiency, right? You can have that wide-based gait, right? Could be something, up in the cerebellum, right? When you think about ataxia, you're thinking about cerebellar diseases, stuff like that. I saw a hand up there. Yeah, cerebellar, right? Those are things we see. There's also like toxins, right? So people who have chronic alcohol use, they can have sort of like paresthesias and numbness and stuff like that in their legs. So you can see that even beyond just like the deficiencies that it might have. What's interesting is folate. Sometimes we forget about folate actually can cause some altered mental status, although very, very rare in this country, right? Folic acid having a deficiency is very, very rare. Thinking about QI stuff, we probably shouldn't be studying folates a ton unless we've got an idea, because it's very hard to get folate deficiency in this country. Can you go back to what else? There are a lot of symptoms.
Oh, yeah, yeah.
And then the 20-pound weight loss over 6 months. What are we thinking about that? What's that? Cancer, right? What else? Infection, so some chronic infection, some sort of chronic inflammation, right? And it might lead to some deficiencies too, right? If she's not eating or something like that. So maybe we don't know anything about her eating habits. Does she have dysphagia? Does she have anything like that? Oh, you said no dysphagia, right? Did you say that?
Yeah, well, maybe not, but no dysphagia.
No dysphagia, right? So maybe it's not, that doesn't sort of add to the nutritional aspects. So right now, I'm pretty curious because there's so many things going on, but maybe some sort of vitamin deficiency, maybe, but sort of common things being common, like some sort of vascular dementia or some sort of dementia like that might be a reasonable thing. And maybe she's just not eating as much, and that's why the weight loss. But the wide-based gait is kind of what throws it off and makes you think about more sort of neurologic issues or deficiencies or something like that that might sort of explain all those together.
Okay, alrighty. I really appreciate the interactive discussion. Let me give you a little bit more information about the patient herself. So medical history, we kind of already went over. It is TTR familial amyloidosis. No surgical history. In terms of family history, some colon cancer, prostate cancer, and lung cancer in her aunt, father, and grandfather, respectively. And then her brother and sister also have a diagnosis of amyloidosis and peripheral neuropathy. Sulfa allergy in terms of medication, some Tylenol, some cetirizine, some ropinirole. And then social history, again, provided by the husband. She lives in Illinois. She does go to Minnesota often to see family. No known exposures or sick contacts. No drug, alcohol, or tobacco use. And then this was written in the H&P. The brother is a hunter who often brings her deer sausage. Any thoughts on these?
All right, we'll get to the deer sausage. That's always interesting, right? So familial amyloidosis, right? So what's the most common manifestation of that? Cardiac, right? It's mostly cardiac, right? AL is usually can be sort of everything, but renal is the one. And then the AA we often see with like, renal diseases, stuff like that. Mental status changes generally, I think it's usually can be AL or AA, not as much TTR. So probably not a factor here. Maybe it is, but it doesn't seem like it. Doesn't seem like she has any sort of exposures, but the deer sausage is interesting. I think what's interesting about it, though, is more like it doesn't seem like she's the one who's the one, breaking down the deer, which is a little bit different, right? Like it has a little bit more exposures to like different types of infections. But the deer that she's eating the deer sausage, I don't know. Maybe handling it raw, the casing. Okay. Prions, yeah. So CRISPR Yaakov, right? So it could be something like that. Yeah.
Okay.
Anything else? Any other deer ideas? I'm not a hunter, so I'm certainly not. This is not my cup of tea. Any other deer things? Or you do think about like zoonotic infections, right? Around deer. But hopefully she's cooking it before she eats it, right? But then if she's handling it, I think that's the question. Okay.
Yeah.
I don't know if it's a red herring though.
Okay. Yeah. I don't know about specific information of her making the deer sausage versus her brother, but it is a very good thought. In terms of RLS, nothing more from what was already mentioned, the weight loss, the lower extremity symptoms, confusion. I think notably no dysphagia. She didn't have a loss of appetite per her husband. Just kind of thinking about the things that you've mentioned. We're going to go to the physical exam next. Anything you'd be looking for in particular on the physical exam for this type of patient?
I would definitely want to see like if she has any numbness or things in other places other than the legs. I mean, it seems like that's been worked up. Trying to think what else, if we're thinking like mental status things. You know, I definitely want to see her gait, right, and really see what that looks like and see if she has any like proprioception challenges or what is really the numbness. So definitely like a really thorough neuro exam. I definitely want to check out the eyes too and make sure that like there's nothing sort of as a pinpoint that there's something going on at the sort of brain level. I mean, obviously cardiac pulse, but I don't think that's necessarily going to give us a ton. I think what else on differential. Yeah, I think of just a really good neuro exam and definitely like walking her, sitting her up, seeing if she can even do those things.
Okay,
Yeah.
perfect. So unfortunately, a lot of that information was not able to be obtained because of a difficult exam. But this is what the initial HMP had. So she was normotensive, a little bit tachycardic, a little bit tachypnic, but she was satting fun in room air. She was afebrile. She was thin, but not really in an acute distress. The majority of her exam was negative, besides the neuro exam, which was listed as difficult because of her cooperation. But she was poorly attentive. She was largely mute when asked questions. She'd barely respond. The cranial nerves exam was just noted to be difficult to examine, but no clear abnormalities. They were able to elicit intact reflexes, and they were able to visualize some full motor strength in her upper extremities, but then they'd also note some intermittent jerking of her right arm. What are your thoughts on this exam?
Yeah. So I think the fact that she's so poor, her mental status is that poor is very, very concerning, making me think of a more like global or very serious neurologic issue. I mean, I think the thing that struck me most was this intermittent jerking of the right arm. So could she possibly be having seizures too? Is she having some underlying seizures that are causing her to be this sort of chronic mental status changes? You know, it does make me, you know, we talked about neurosyphilis, you know, that can sort of mimic all these things. That could certainly be something that I'd be thinking about. We talked about B12 deficiency. I guess it could be. It doesn't seem as sort of likely here. I would also be concerned about like vascular diseases, like, you know, strokes and things like that in her. I'd also be a little concerned about like something more systemic, like a more systemic infection. So yeah, it's definitely a concerning physical exam. Any other thoughts from the group?
There was a recent case report in the journal where a young female had, I don't want to say similar presentation, but and
Oh, that's right. I think I saw that same one. Yeah, interesting. So getting tops open there. Yeah, I like it. I like it.
I love it. Okay, well, why don't we get on to some diagnostics, if that's okay with you. We will start out by showing you some basic labs and some of the basic workup that was done in the ED. So initial labs, the numbers, if they were abnormal, will be red. As you can see, there's no red. So the CBC and CMP were largely unremarkable. Does this rule anything out for you or help you in any way?
I'm gonna think through my differential. I guess not really. I mean, it does. I think thinking about a nutritional deficiency seems less likely since it seems like most of the other labs are like pretty normal, although it doesn't totally rule it out. But I think it more or less goes along with some sort of chronic indolent disease, right? That the other things. The other thing is though, you don't see a lot of like chronic inflammation that you would see, right? The platelets aren't really high.
Yeah.
You know, albumin is not really low. So, you know, sort of chronic inflammation seems less likely or sort of chronic infection, but I guess it could still be on the differential.
Sure, definitely. And then here's a chest X-ray. Would you mind giving us your impression of this chest
Yeah.
X-ray?
So
Might be a little hard to see on this big screen.
So we always start with, is it a good X-ray, right? And so probably it's a little over-penetrated because you can see the vertebrae a little too clearly, or maybe the monitor here is really good. And then you took about inspiration. It's 1, 2, 3, 4, 5, 6. So has a lot of ribs, so probably good inspiratory film. It's a little rotated to the right. You can see a little bit of distance between the right clavicle and the vertebrae. And then I always go outside in. So looking at bones and soft tissue, I don't see anything particularly there. The diaphragms look normal. The angles look pretty clear. And then you look at the parenchyma and the heart, all look pretty normal. Maybe there's some increased hilar fullness, mediastinal hilar fullness. Maybe there's some nodes there, but pretty mild, I would say.
Yeah, I actually agreed with you.
Yeah.
I agree with you when I first saw that. I had
Yeah.
the same thoughts. It was read ultimately as normal, but certainly agree with you on that. And then the CT head that was obtained in the ED, I'm not going to make you read this, but essentially it was read as completely normal, no acute events or any abnormalities on it. Does this CT head being normal help you in any way?
Certainly toxo would probably be a little less likely, right? Because you should see something if it was really that widespread, although you still may not see it. You still may need an MRI. It does rule out, structural things like, could she have had, large ventricles, things like that, but those are all normal. If you thought that she was having a lot of like vascular dementia disease, you should pick up something like some of small strokes or things like that you see, but it's pretty normal. The other thing is like, if we do think it's some sort of dementia or sort of chronic brain things, you might see a little less volume, but you don't really see that. So it's totally normal CT basically.
Yeah.
Okay. All right.
Okay. Well, so that's kind of the basic workup. What kind of basic labs or workup would you be interested in getting now?
Yeah, so now we're thinking, I would still do the usual, what we always do, the usual mental stats workup, right?
Sure.
We always get like TSH, the B12, the RPR. Syphilis is still certainly something we can think about. So I would definitely get an RPR. And then I'm trying to think beyond that. You get the B12. I probably wouldn't get a folate, but I probably would still get the B12. And then other things on our differential. If we're thinking, so right now our differential is still probably like some sort of dementia type thing, right? Although it seems less. And then we're thinking the deficiency, so I get the B12. We're still thinking neurosyphilis. I'd probably definitely want to get an MRI of her for sure. And so in my mind, I'm thinking MRI and definitely like an LP. I don't know if like serum things. If we're really concerned about like chronic fungal infections, things like that, although there's nothing really pointing that way, right? Here we have a lot of like, here it's a lot of like histo and blasto and cocci, but those are usually like pulmonary manifestations, which we don't really see a ton of. So I don't know if that's necessarily the tree we want to bark up, but I'd probably just start with the basic labs and an MRI and see if that helps us.
Okay, well, why don't I give you the labs and let's say you order the MRI, but it's the weekend, so we're waiting on that for a little bit. The vitamin B12, as you mentioned, was normal. Folate was normal. Thiamine was normal. Vitamin D and TSH were also normal. So help ruling a few things off of your list there. And then I think you mentioned some infectious workup as well. And so RPP negative, blood cultures negative, HIV and RPR negative as well.
Okay, so all
Maybe
negative.
narrowing some things down for you.
That's good. That's good for her, right?
Good for her, maybe not good for you, but we'll see.
Not good to try to figure out what's going on.
And then I can just show you a few of the other labs we got.
Yeah.
So we got UA, urine studies, essentially some turbid fluid, a little bit of blood and nitrites and leukocyte esterase in there, some trace bacteria and some mucus present, but the white count was only 6 to 10. So it actually didn't reflex to culture. And then they got a UDS as well, which was negative on this patient. And I think you mentioned a VBG as well. As something you like to look into. So the pH was 7.39 with the CO2 of 51. Do you make anything of this?
Not much. I mean, PCO2 is maybe a little high, but you
Yeah.
know, it's a VBG,
Yeah.
so it's pretty normal,
Okay.
honestly. So I don't think it certainly explains our altered mental status, and
Yeah.
probably not something we'd be worried about for someone who's had a chronic mental status changes over 2 months or 3 months or something like that. So really right now we're left with, she has these paresthesias, this gait thing, totally altered, has some sort of chronic, you know, jerking or something. So I definitely want like an MRI, like an EEG probably.
Yeah.
I definitely would really probably do an LP too, and just ensure that she doesn't have some sort of like encephalitis or something like that. That could be something chronic. So those are the things I would definitely want to do. with this
Absolutely.
very basic workup being negative.
Those all sound like great ideas. Before we get to those studies, at this point, the primary team was pretty concerned, and so they did consult neurology. And so neurology actually saw this patient and gave a very detailed exam. So that might get you some of the answers you were looking for from before. So I'll just kind of summarize some of this, but take your time to read it, and then you can let us know your impression. So in terms of mental status, she was hypervigilant and she was poorly attentive. Like I said before, oriented to only herself. In terms of language, she was mute for the most part, but sometimes she'd answer with some really short phrases, and sometimes she'd follow some simple verbal commands, but not much. Cranial nerve exam, really not too much there in terms of her pupil exam. No nystagmus, there was some restricted upgaze, but really not too much there. In terms of her motor exam, she was bradykinetic. She had diffuse atrophy. They did note intermittent myoclonus in the bilateral upper extremities. And then they also noted hypertonia versus paratonia throughout, and that she was moving all her extremities equally, but not synchronously. Reflexes were intact. Sensation was intact for their exam. And then she had some ataxia with reaching in the left upper limb for the coordination portion of the exam. Anything stick out to you here on this million-word
I
slide?
think the ataxia across like just even is not even just lower, it's also upper limb.
Mhm.
So, you know, when you think lower limb, you're thinking like peripheral things, but now this seems to be very diffuse. So you're thinking about it, is this more of like a spine or like brain, more central nervous issue?
Mhm.
And the diffuse atrophy also makes you think that there's sort of something sort of globally from a central nervous system issue as opposed to just being peripheral. And there's myoclonus too, which also makes you think sort of central, right? There's no sort of negative feedback to sort of keep things calm. And then, let's see what else here. Yeah, it does really make me think central. So really like, would really want to get this MRI, really want to get an LP, get an EEG, really want to see what that all looks like.
Okay,
Yeah.
well, why don't we get you some of those things? So we'll start out with the EEG. It showed right hemispheric slowing and mod-gen slowing with some triphasic waves. Essentially, it was summarized as generalized slowing with triphasic waves, indicating diffuse cerebral dysfunction, as seen in metabolic, toxic, or diffuse, or multifocal structural abnormalities. Does this help you at all, or does this just frustrate you?
You know what does it? I mean, it's actually reads more better than a lot of them, right? But
Yeah.
the focal slowing, I think, does make you think about that there is something structurally going on in the brain. So I think that actually is what caught my eye. And in the fact that it seems to be more right-sided, so it does make you think there's something going on in the brain that is like there's some nidus or some issue. Because usually what I see is the last one. I just see
Yeah.
that.
That last line.
Right. And then I'm just like, okay, not very helpful. So,
Yeah, I agree. Well, why don't we're going to pull up the brain MRI here soon, but would you mind kind of summarizing your differential at this point? What do
Sure.
you think you might be going on?
So I
before
think
get-
we started with this sort of broad differential of acute things, metabolic, neuro, geriatrics, all that stuff seems to be pretty normal. I think we started with maybe an infectious, some sort of vitamin deficiency. We started thinking about dementia. And all the sort of workup for all of that has been pretty negative. So what we're really looking at is like, at this point in my mind, I don't have like a great, like, this is what it is, or this is what it could be. But I do think that there's something structurally wrong or something's going on in the central nervous system that we need to sort of investigate more. We still haven't really ruled out like an infectious encephalitis. So I do think an LP is still something we have to get.
Mhm.
But yeah, that's probably what I'm thinking. I don't have a particular diagnosis in mind.
Okay, well, let's see if the brain MRI can help you. So we have Dr. Boyle with the radiology department. Thank you for joining us, Dr. Boyle. He'll go over some of the images.
I guess it could still be toxo, right? Possibly, but thank you, Thomas. But yeah.
So this is an MR of the brain. It's with and without contrast. I sort of opened with, it's a kind of a busy study, so bear with me here. So these are just axial slices through there. And what I'd like to call your attention to is that, again, we don't really see any sort of ventriculomegaly, but there are all these areas. And this is one of those ones where we have to look kind of back and forth between the two sides of the brain. And we always have this saying that like diffuse and sort of symmetric abnormalities are the hardest to see just because your internal controls get thrown off. So if you look a little bit closely here, you can sort of see these bright sort of T2 flare hyperintensities in this sort of subcortical white matter. Do you not? Oh, is it? Oh, I see. I see. So you can sort of see these bright T2 flare hyperintensities in the subcortical white matter. I think another thing here that might sort of stick out to you is that some of the cortical gray matter here in the right frontal lobe and sort of midline may be a little bit thicker, maybe a little bit more hyperintense than say the other side. Especially like if you juxtapose it to some parts of the parietal lobe back here. The other thing you might notice as well is you've got this brightness in this one caudate and not on the other caudate. That's not normal. These should be symmetric and not that bright. Another thing that's kind of difficult to show on static images is that there's actually some T2 hyperintensity in her mammillary bodies and floor of her third ventricle. That's also a different finding. And you can see that this cortical T2 flare extends really up all the way up into like the superior frontal lobes bilaterally.
So it's more right-sided.
Yeah, I would
Than
say
left.
slightly asymmetric, right versus left.
Okay. And it's pretty diffusely around the brain, right? It's
Yeah.
not just in one particular
Right.
area. It's sort of like in all the brain stem all the way up around.
Right, and
Okay.
sort of, interestingly, it seems to, there's a couple of those little bright spots that are in the white matter, but it's predominantly a gray matter process, considering it's the cortex and then also like the deep gray, like the caudate. So it's something to think about. The other thing that's very interesting here is that those areas of T2 flare hyperintensity correspond to asymmetric restricted diffusion, also in a very gray matter sort of distribution. So again, these areas, this is one of those ones you get to go back and forth, but you can sort of see this ribbon here of this restricted diffusion, and also the caudate is also involved. We didn't really see too much restricted diffusion in the third ventricle or the mammillary bodies. We just saw the flare of the mammillary there. So corresponding with those findings, you've got restricted diffusion and true restricted diffusion since we have both the ADC and the DWI. And this is just to show, as you scroll superiorly, you also then do sort of get more extensive right greater than left involvement of all of these, a lot of these gyri. I think pertinent negatives here were the ventricles were not enlarged. We didn't see anything that looked like intracranial hemorrhage. And I think those are sort of the major differences or pertinent negatives. This was a post-contrast study and none of this demonstrated enhancement. So this was all predominantly flare and restricted diffusion.
Okay.
This is sort of where I'll kind of get the differential here. So whenever you have
Please.
whenever you have this sort of like multifocal restricted diffusion, sort of involving like multiple lobes and then also deep gray structures, it gets a little bit difficult to call this like a pure vascular phenomena because we're not playing by any territories here. This is something that seems to be focusing on gray matter. And so the differential for this would be something like a spongiform encephalopathy, an autoimmune encephalitis. Other things that would be a little bit less typical would be sort of like if you had a profound hypoglycemic episode, post-ictal, something along those lines, and even just hypoxia. Although typically if you see, there's usually a sort of better defined way. If you see like a profuse anoxic injury, you sort of see it more, maybe a little bit more symmetric, maybe a little bit more in these watershed territories. And so that would be the differential.
So this differential is spongiform
Encephalopathy, like Creutzfeldt-Jakob or autoimmune encephalitis.
autoimmune
The other thing to think
or-
about is given the presence of that flare abnormality in the mammillary bodies, you could think about Wernicke's encephalopathy, something like that. That's one of the things you can see.
Right.
I did want to show this because this is one of those things I feel like sometimes you guys just have to kind of take our word for it, but I try to find an age and gender match control on the DWI sequences. So you can kind of say, okay, Joe, it probably maybe is abnormal because this is brighter than this should be on both sides. And you can see over here. The thalamus is definitely, the caudate's definitely abnormal here and here. So it's one of those things you have to look back and forth, back and forth, back and forth to kind of make sure, convince yourself that it does exist. So, but that was my little teaching point.
Oh, okay. Nice. So maybe it is the deer, right? So it's interesting. And so then autoimmune encephalitis. So, wow. I mean, I think you still are left with, you could send markers for autoimmune encephalitis. I would be seems very unlikely given her presentation and some of the other stuff, but it's probably worth sending that types of study since we're not really sure what's going on.
Yeah.
I think for thinking about the prions disease, I think you have to do some sort of brain biopsy. I wouldn't necessarily do that. You probably still need to do an LP to just rule out, these, some sort of chronic other encephalitis, although it seems like the differential is pretty narrow based on what you're seeing on that. So maybe it's just sort of, that's the diagnosis and then we have to treat it from there. But yeah.
Yeah, that's pretty interesting. So I got the LP up next. And so I guess what kind of tests would you want ordered on this LP when they're?
Yeah, so I'd be really looking at like the protein, right? If they have a high protein, is that some sort of idea of an encephalitis? This is not really an acute meningitis, so I'm not like that concerned. I mean, obviously you're going to send a gram stain and all of that stuff. You probably end up also sending, you probably want to rule out like HSV, that type of thing. It seems very unlikely. And then for Christoph Jakob, I think you can send it out for some special tests. I don't exactly remember what those are, but I'm sure I would call neuro and ask them what those would be, but those are certainly things that I would send.
Yeah, that's what up-to-date in neurology is
Yeah,
for.
exactly.
So the CSF, the glucose came back normal, protein was elevated. There was a normal amount of nucleated cells, red blood cells. The cultures came back negative. Oligoclonal bands were negative and IgG index was normal as well, which can help with the diagnosis of autoimmune encephalitis. And then the markers that you were looking for. So the 1433 was markedly positive, the t-tau protein was markedly positive, and RT-QuIC was positive as well, if those bring any memories back.
They don't bring any memories.
No.
But the tau protein is probably
The
the
tau
one that is
protein.
the one that maybe brings something back.
Yeah,
Yeah.
absolutely.
Very cool.
So do you think based on those you can make a diagnosis?
I think so. And based
Okay.
off the MRI and then based off, her
100%.
sort of general presentation is sort of acute, mental status changes, things like that. And then maybe that is this deer thing that's also part of it. It's hard to know for sure, but certainly it would probably be enough. It's, from my understanding, it's really a sort of a clinical diagnosis, and then you have actually these markers. So you're pretty much diagnosing it at this point.
Okay, alrighty. So then the diagnosis, like you're mentioning,
Yeah.
CJD for this patient. Good job, Dr. Chang. And so I have a few interesting thoughts on actually what you've been saying, but to round out the hospital course, the patient was quickly transitioned to comfort care and passed away within 10 days of diagnosis. CJD, very interesting point about the deer sausage, Dr. Wren. Nobody actually ever mentioned that in the notes. They just put it in like the initial HPI, but then no one related it back to the diagnosis. Yeah. Yeah, absolutely. So it was assumed to be sporadic. There's 4 types of CJD. There's sporadic, genetic, variant, and iatrogenic. Sporadic is the one that's a large majority of time, 85 to 90% of patients. There's also genetic type as well. And then there's 2 acquired types, variant and iatrogenic. Variant is like mad cow disease or like Kuru cannibalism, somewhere you like are exposed to the prion itself, and then iatrogenic obviously in the hospital. The prevalence is 1 to 2 people per 1 million yearly. Some reports say that, or some studies show it's actually less than that. And in terms of clinical features, you want to look at for neuropsych features, myoclonus like this patient had, and then cerebellar symptoms like this patient had as well. That can be the first presenting sign in about 20 to 40% of patients. And then the diagnosis, you are correct, Dr. Chang. So it can be made multiple ways. It can, if you have a list of clinical features and you meet multiple of those features, and then you also have a positive brain MRI or EEG or 1433, then that's enough to make the diagnosis. So based on the imaging and the clinical features itself, you can make that diagnosis. They did get the markers in this case, just to be sure. And then the RT-QuIC is the alternative step to the diagnosis. It is the most sensitive and specific test and is actually the preferred test now for CJD diagnosis. So thank you, Dr. Chang, for joining us, and thank you everyone for joining us today.
Thanks.
Thanks, Dr. Ray. Yeah, no, I don't really want to.
And it's up. Everything has.
Yeah, it's. No. I mean, but you could actually diagnose. It's kind of hard.